everyone, to our webinar, Drummond and Shift, Building Tomorrow's Privacy Interoperability Landscape. My name is Lynn, and I'm the Field Marketing Manager here at Drummond. In this session, Drummond and Shift came together to dive into one of the most pressing challenges in healthcare, how to give patients real control of their data while navigating privacy, regulatory, and technical complexities. You'll hear patient stories that bring the issue to life, see innovative tools like Fireplace and Shift Sandbox in action, and learn how collaborative efforts are driving scalable, standard-based consent solutions. Now I'll have today's speakers introduce themselves, starting with Hannah Galvin.
Hi, my name is Hannah Galvin. I'm the co-founder and board chair of Shift. My day job is as Chief Health Information Officer and Interim Chief of Pediatrics at Cambridge Health Alliance, which is a public academic health system in the Boston area. And I'm delighted to be here. Serena?
Hi, everyone. I am Serena Mack. I am the Senior Project Manager for Shift. And then I also work at Drummond as a Revenue Operations Strategist. Mohammad.
Mohammad Jafari. I'm the Technical Director of Shift. And my other capacities, I work independently with various technical and business consulting projects. But most notably, I'm the technical co-lead of the consent management and identity management IGs with the FHIR at Scale initiative, and also a member of the Sequoia Privacy and Consent Work Group.
And it looks like Tim is just running a few minutes behind, but I'm just going to give him a quick intro here. We are also joined by Timothy Bennett, who'll jump on a little bit later. He is one of our governing board members and also the director of the strategic healthcare initiatives at Drummond with me.
Great. Let's kick it off here. We're going to start by talking about what is granular segmentation and what is equitable interoperability. Shift has sort of coined this term, equitable interoperability, so we'll talk about that a little bit and what's the problem here that we're trying to solve. Then we'll launch into sort of what is Shift, why were we founded, what is it that we do, and then what are our proposed solutions, what's next, what is this collaboration that we are working on together with Drummond. So next slide, please. So what is Shift and why did Shift form? In general, we have seen, those of us who've been working in this space for the past decade or two, that there's a lack of trust in the healthcare system. This trust is higher and is known to be higher in historically marginalized populations. And as we in the health IT industry have built out the pipelines to connect data and this interoperability roadmap across the country, which is a great thing and improves care, it improves care quality. What we've seen is that those who are at the margins are often not only left behind, but experience this as threatening to their ability to receive care. So here's a story of one young man as a composite of many patients actually that I have seen in my clinical practice. This is a story of when I was seeing patients on a mobile medical van doing street medicine. This is a young man who was actually hit by a truck, a person versus truck accident. I needed to send him to the emergency room to get some imaging done to make sure that he was okay and wasn't internally bleeding. And this is a young person who had a history of substance use disorder. And he said to me, I don't want to go to the emergency room. They're just going to think that I'm seeking drugs, that I'm wanting to get opiates from them. They're not going to believe me. And I heard this many, many, many times. I've continued to hear this throughout my practice with marginalized populations, that my record is going to precede me. I'm not going to be believed. And there's a real hesitancy to seek care. So as we are building out these pipelines and sharing data, which can be a very good thing, there are also members of the population and members of many communities that become more hesitant to seek care. Here's another use case, and these are real cases, though I've sort of made the details of the story composite, but we've heard stories of parents, in this case a mom, who tells her pediatrician that she's having trouble with food and providing food for her child and is having financial insecurity. And these types of social drivers of health, for the past 5-10 years, we have really been learning as health industry and community that it's really important to collect this type of data so that we can help people to get the care that they need to meet these health-related social needs. That's fine as long, actually, previous slide, please. That is fine as long as we can keep that data private when it's sensitive. In this case, this mom shared that data with her provider, and that provider wrote that data down in their note, but this child's father, the other parent, had access to that information, access to that data through the portal, and used it in a custody battle to get full custody of the child. That worsened mom's medical mistrust of the system. She shared that data in confidence. And we have heard stories like this over and over again. The next slide, please. So we hear lots of these stories, not just from historically marginalized populations, but from all areas of the community, and realize that we need a better system to protect patient-sensitive data. And what can be sensitive for one person may not be sensitive for another person. If I had a knee injury, that wouldn't be sensitive for me. I don't mind if all of you know if I have a knee injury. But if Patrick Mahomes has a knee injury, that may be sensitive for him. What we find is that patients are starting to avoid care, or they are starting to not tell us as doctors or as care providers everything because they are afraid of how that data may be used. Once that data is out there, patients are smart. They realize that now that data traverses lots of different entities. Once the data is out there, it can't be brought back and it can't be taken back. And as I mentioned, historically marginalized populations are disproportionately affected in these cases. We see this in the data as well. This is a survey that was done by the American Medical Association and an independent research cooperative a couple of years ago. And they showed that the majority of patients, almost 60% of patients, had concerns about how their health data was being used and were concerned that it could be used against them in certain situations. This was much, much, much higher in historically marginalized populations, specifically racial and sexual minorities and ethnic minorities. And of those surveyed, about 80% of patients want some way to opt out of sharing their data in certain circumstances, not in all circumstances. Next slide, please. There's a much larger study called the HINT-6 study, also published a couple of years ago, that shows that when patients share their health-related social needs specifically, they are less likely to want that data shared if they had a recent experience with health-related social needs, needing help from the system to meet those needs. If they have decreased trust in the system, if they have received poor care recently, or if they've experienced discrimination. So all of the patients that have recently experienced these issues with care, or who have actually experienced health-related social needs, as opposed to many people just talking about health-related social needs, we're less likely to actually want this information shared broadly. Next slide, please. We know that when laws change, so just a couple of years ago when the state of Florida enacted a law that required reporting of immigration status to the state, we see on a broad scale those who had a sort of undocumented immigration status not going to seek care. So we see that on a sort of population level scale, people don't seek care when they are afraid for how their data is going to be shared. Next slide, please. We hear this in qualitative data as well. You may know Open Notes. They are the academic lab behind the framework, the Open Notes framework, which is how with 21st Century Cures, we are now all sharing our notes and have access to our own notes as patients, which is really fantastic. And there's a lot of data behind why this is helpful. And they have done several studies looking at patient perspectives. And we see from some of these comments that patients are particularly concerned about who is getting their information. And if it's not relevant to the particular care that they need at that time, then they may not want that information shared. They're worried about being judged. They're worried about how that data is being shared. And so it's reflected both in sort of the broader quantitative studies and in some of these qualitative comments as well. Next slide. So how does this affect equity and the whole ecosystem? Well, interoperability is a fantastic thing. If I am somebody who is not worried about how my data is being shared, then all of these pipelines that we have built have enabled me to be able to go to another health system. Let's say I end up in the emergency room. I go to that health system, and the doctor caring for me has a lot of information that is relevant to my care, my problems, my medications, my allergies, my care team, that helps them provide the best care to me that's possible with all of this technology that we've been working on for the past several years, past several decades. Similarly, if I have a family member that's helping me get to appointments, they can also access a lot of that information, appointment information, medications, and help care for me through the portal. But now if I have sensitive data, however that's defined, if that's defined by federal law or state law, or just by my preferences, by my experience of stigma in the past, right? And I don't want to share all of my data. In our current ecosystem, the only way that I can really do that is to turn data sharing all the way off. It's a very blunt mechanism. And if I do that, when I end up at that other hospital, or when I end up, when my family member ends up trying to help me through the patient portal, they don't see all of that data. And now I end up getting meaningfully different, and I would say meaningfully lower quality care than somebody without sensitive data. And so inadvertently, by not allowing for more granular mechanisms to control sensitive data, we have inadvertently created disparities in the system between those who do not have sensitive data and those who do have sensitive data. Next slide. And this is what we refer to as equitable interoperability, or more equitable interoperability, which is the goal being to ensure that all patients, regardless of whether they have sensitive data or don't have sensitive data, that their privacy considerations are taken into account, and that everyone can benefit from the type of seamless health data sharing that we've been all working together to develop over the past 2 decades. The all or nothing approach that we have today is very limiting to many populations, and to many populations who are not able to necessarily advocate at the highest levels of government or highest levels of the health IT industry for their needs. We at Shift want interoperability to work for everyone, and that is what we are building towards and what we advocate towards. Next slide. So how does this work? There have been data segmentation standards for over a decade now. Many of you may be familiar with some of these previous pilots, these previous efforts. DS4P, Data Segmentation for Privacy, it was a CDA standard. It is now a FHIR standard. This is a little bit of the trajectory that has continued over the past decade. And it has been piloted in several different milieus and different venues, and yet there is not widespread adoption. Why not? Next slide. Well, there's technology, but it's only part of the solution. There are a lot of different stakeholders that have to come to consensus on key issues to balance privacy and safety. For instance, right, we can segment patient data, but is that safe to do? If I say I have a behavioral health condition like depression, and I say I really don't want to share that with my podiatrist, and my podiatrist prescribes me a medication that can interact with my antidepressant, is that safe? That feels like a barrier, and that has been a barrier in the widespread adoption of these types of technologies. So the technology is only part of it here. We have to really understand these nuanced concerns, and we'll talk about that a little later on. There's a ton of fragmentation across the regulatory environment. There is no harmonization of state laws. The state laws are incredibly different. There's differences between the state laws and the federal laws. And so that is very challenging as well. There are a ton of different nuances and edge cases that we could get lost and talk about for days or decades, as it were. And if we get lost in all of the little weeds, then it becomes harder to stay on task and stay on a path to solve the larger issues and achieve deliverables. It can be very challenging to align the industry as well and find wins that everyone agrees on, right? There are a lot of different viewpoints. Vendors may find different, have a different viewpoint on what is a win here than patients do, than providers do. So that alignment can be very challenging. And so what have we done to try to address this? Because just kicking the can down the road is not an option if we aren't going to leave a good proportion of our population behind. Serena?
So I'd like to talk a little bit just about Shift and who we are. We are an independent, nonpartisan collaborative that is dedicated to advancing safe, but most importantly, patient-empowered health information sharing. We were founded in 2018, and since then we've grown to about 300 stakeholders across the entire healthcare ecosystem. And we focus mostly on patient autonomy, allowing patients to decide what is sensitive to them. We are leveraging robust technical standards like FHIR, but also additional standards, which we'll get into a little bit later, and also practical guidance for real-world implementation, understanding that there is a lot of complexity to this issue. So you've already met Hannah and myself. We're also very happy to have Abby Worthen and Amit Trivedi on our leadership team as well. We have our governing board. The governing board provides both guidance and also really drives our work forward. So we'd like to say a big thank you to the AAP, the AMA, Drummond, the EHRA, IHE, and also the ASTP, who sit on in an ex officio capacity. I know that's a lot of acronyms, but many hands make light work, right? So our approach is really to start with that inclusive collaboration, bring everybody to the table from the entire ecosystem. Legal experts, ethical experts, policy, patients, making sure there's clinicians and vendors and insurance payers, everybody at the table. We are really focusing on being patient-centered and politically neutral. We are focusing on a couple of our high-impact use cases, which I will go over in, I believe, the next slide. We are building on a lot of the existing frameworks and tech that are there, and also making sure that our growth is sequential, not trying to do everything all at the very beginning, but making sure that we are building off of our beginning work here. And we also use a Delphi method for gathering consensus across the many areas of expertise. So we are starting with our 4 use cases. We have our older adult behavioral health use case. This use case is currently in front of our technical work, who are using this use case to build out some of the initial reference implementations. We have our adolescent reproductive health use case, our adult social drivers of health, which we are super lucky to have the Futures Without Violence and Gravity project collaboration with. So big thank you to them as well. And then our final, for now, use case is the commingled maternal infant use case. So this is kind of our organization structure. We have 3 different work streams. the terminology and technical work streams. Mohammad is going to go into a little bit more about what they do. Our implementation work stream, that is our Delphi process that I mentioned a little bit earlier. And then all in all, we are guided by our 4 different advisory groups to make sure that all of the work that we do is ethical and equitable, that we are getting clinicians at the table, patients at the table, and also kind of monitoring the ever-changing regulatory landscape that is healthcare. So I mentioned the Delphi process a little bit here. We've done 3 different topics of these. Our 4th is about to kick off next week. And what a Delphi process is it's a way for a group of experts to get to consensus on a specific topic or a concept through multiple rounds of feedback and discussion. I'm sorry, it started to really rain outside. Hopefully you can't hear that. I apologize. So we have completed our informed consent, safety and ethics of redaction, and our notification to intended recipient. Our next topic is discussing the algorithmic decision support, so DSI tools, CDS, AI, all that fun stuff. We are accepting participation up until August 31st. So if you feel like you are an expert in any of these areas and would like to participate in kind of coming to consensus on how redacted information should be used in these algorithmic tools, we would be happy to have you here. And now I'm going to pass it over to Mohammad.
Great, thank you. So, the technical stream basically was started by bringing, the technical expertise and also the experience of existing standards and specification in order to instantiate and show in a very pragmatic way what kind of infrastructure and what kind of technical infrastructure we need in order to support the use cases here that we are trying to build. And, we have a collection of open source products that we basically brought from existing prior art. And we worked on those standards, both in the sense of like standard development and implementation guides, as well as improving the actual products and the open source implementations in order to establish the sandbox there. And the ultimate goal is to basically support the use cases that we have in conjunction and in tandem with the other work streams that we have with the terminology work group and the Delphi process and what's going on with the entire process of the upstream expertise that we are basically following. Next slide, please. So there are the components that we have here are basically the data segmentation for privacy. This is sort of one of the primary standard. Data segmentation for privacy has had a history of almost a decade, at least at HL7, for providing guidance on how to provide finer grain access control and break down the data in order to identify the parts of data that it requires additional protection. And then there's different varieties and different flavors of the standard for different data structures and different protocols. And that basically provides the background for what we have in terms of understanding how to sequester the data that is additionally protected and be able to make that data subject to additional protection according to the policy. And then from a pragmatic perspective, we have to have a data tagging service. This is basically the service that implements data segmentation by applying security labeling. And then for the other aspect, which is basically the policies that are directed by the patients, we are following the FHIR-based consent management standards. There are other consent management and consent standards, both from the perspective of like the content of the consent, as well as the way the consent is collected and managed. There's other standards that are existing, but what is the latest and greatest and also being advanced by the industry right now is within the FHIR. And specifically, there is a IHE privacy consent on FHIR, which is the profile that actually brings all these components together for the specific use cases of privacy consent. And then ultimately, we want to be able, and I'll speak to this a little bit more in detail in the following slides, to be able to enforce policies at the on the fly and in real time, as well as for data at rest. So these are two wings of the same technology. There's two ways to frame the same technology in order to address the requirements for different use cases that we have. Next slide, please. And then this is the kind of the hierarchy of the maturity model of the use cases that we've targeted. And this is sort of a vertical slice and kind of orthogonal to what we discussed before in terms of the target use case from a clinical perspective. These are the slices from a technical perspective that sort of are conjoined with the other sort of clinical level use cases. So one use case is to show basically the security labeling within an EHR, just showing the data is labeled at rest, and we are able to actually discern and distinguish the data that is additionally protected, and be able to enforce that at some level based on some policies. So I think being able to identify is the crux of being able to enforce any sort of policy. While the policy can be flexible, it could be, for example, just marking the data in a user interface, or maybe hiding it from specific use cases or specific users. So these are the policy itself can be flexible, but the crux of it is to be able to actually identify the sensitive data in order to be able to make that subject to different policies. The next iteration is basically to be able to enforce policies based on data segmentation and based on identification of sensitive data in exchange scenarios. So we have these mock EHRs that trying to exchange the data, and we are trying to show in these demos that we are able to actually identify sensitive data and then enforce what can be transferred according to policies. These policies in this level, the second demo, are basically assumed to be sort of hard-coded or overarching or available in the system, which takes me to the next level, which is the being able to enforce this based on consent decisions. So we are trying to combine in this level the identification of sensitive data with consent decisions and the policy that is driven by the patient choices. And then ultimately, I think to put it all together, that also would require having a consent management piece where we also show the part where the patient actually enters their preferences into the system. So rather than assuming that policy fragment, the patient consent exists already in the system, we also show that how the patient can change that, and the piece that is the consent management piece is also included in the demo. So this is how we sort of orchestrated this in terms of more advanced levels of maturity as we move forward. We've been able to show 1, 2, and 3 different, in Isolation Act, we demonstrated with some partners the third demo, but the first and second demo were more substantiated within the Sandbox, which I will speak to a little bit further. Next slide, please. So this is sort of a higher level view of the security labeling service for a scenario where we have the data at rest. And I think the diagrams that we have here, these are the technical diagrams that we have for the work that we've done in the Sandbox. In the core here, we have the batch orchestrator. The batch orchestrator is basically, the piece that kind of brings everything together, because we have a security labeling service that is capable of labeling the data and identifying sensitive data. And the way we interact with that service in order to integrate it with the rest of the organizational workflow is basically a determinant of how the security labeling service is used. So in this scenario, we're trying to use this for data at rest. And what happens is that we have this FHIR data source, which is a FHIR server, and we are monitoring that FHIR data source to see when new data is created or updated. So if there's new data coming into the system or existing data is updated, we're monitoring those events using a FHIR subscription. And then that FHIR subscription triggers a labeling queue that would schedule the data to be labeled. So if data has changed or there's new data has emerged, then it needs to be subject to new security labeling, a re-invocation of the security labeling. And the way the security labeling was configured in this particular instance is that it generates a transaction bundle, which basically invokes the required commands within a FHIR server to apply the security labels. So rather than putting the labels on the data directly, we generate the instructions. It's sort of like a snippet of code that when it is handed to the FHIR server, would actually update and apply the security labels to the data as expected. Next slide, please. So this is the alternative scenario where we are actually using the security labeling service in the context of the transaction. And this diagram particularly, we use this for HIMSS, also includes the consent decision service and the consent management part, which we did not include in our demo. However, we've basically demoed everything that is to the left-hand side of consent management service. So from the FHIR consent source all the way to enforcing the policies from a consent, we have demoed this. This demo was not part of the Sandbox at the time, so we did like a one-off demo with some partners to just show these capabilities. But I'll go very briefly over the flow here. So we have a request, and the distinction here is that data is not at rest. Data is being requested for an exchange, and we're trying to enforce the policies and label the data as we are trying to share it, basically. So the request basically triggers the flow, and that would trigger the authorization service, which is basically the mediator to control access to the data source, the FHIR server. And once the data that is the subject of that request is identified, we trigger the security labeling service to tag the data to identify the sensitive data. And then once that metadata is available with the data, we're able to also inquire about the consent decision, identify the patient whose data is being shared, find the consents that pertains to that patient and to that transaction applicable to that purpose of use, for example, because there could be consents that are applicable for different scenarios. So we find the relevant consent for the relevant patient. And then in tandem with the labeling of the data, we are able to identify what needs to happen to the data before it's shared. So the decision could be to share the data as it's as is, or potentially labeled data, which is the scenario we're trying to show in our demo. Even if we are sharing the data, we want to apply the labels so that the recipient is aware of the level of sensitivity involved with the data as it's being shared. And then it could also mean that we will redact some data. So based on the policy, if the consent doesn't allow sharing sensitive data or certain classes of sensitive data, then that data would be redacted from those bundles as they're going out of the door. Or it could be like the declining of the transaction entirely. So that would be something that could be the result of a consent decision. For example, if the consent requires that we share no data with the recipient at all, then that transaction could be declined. I think the redaction option provides a kind of a middle ground so that we have more granular control over the data. So rather than having this sort of binary decision that we either allow everything to go out the door or we decline the transaction altogether, we have some more flexible option to be able to apply this more in a more fine-grained way. So we only share what is allowed to be shared, and anything that has been not permitted to be shared will be removed from the outgoing bundle. Next slide, please. So this was a little bit more zoomed in on the security labeling service as it happens for the data at rest. So the event of updating the data or creating new data, this could be triggered by a user, it could be by an import. For example, it could be like a FHIR bulk import. That would be captured, and then that event is sent to the security labeling service through the other component that I showed in the other slide, which was the orchestrator. And then that would apply the labeling to the data, and then what we will store in the system would be the labeled data. So this is basically how we label the data and identify sensitive data for the data at rest. And next slide. So I think this is a little bit more sort of finer grain and with a more high level of the variety of that other diagram that we showed earlier. So we have the security labeling service, we have the redaction service that we didn't show in the other diagram. So this is sort of like zooming in to show that the security labeling service is just identifying the data, but the redaction service is another component that can interact with the orchestrator and the access control system here in order to pluck the data that is sensitive and when it's not allowed to be shared based on the policies. And the policy can also be fed by the consent, as we saw in the previous diagram. So we have been able to demonstrate the latter two diagrams basically within the sandbox. And the other two diagrams that I showed are a little bit more high level, some of which we have showed in sort of like one-off demonstrations, and some of which will be more future work as we are moving forward with the sandbox and the technical work stream. Next slide. And then I think as I spoke kind of like about the sandbox, we've been bringing these components into, sorry, I need to remove my earpiece here. It's not really, I'm getting a weird echo. So we've been bringing these components that are open source. There are most of the components that were developed by the ASTP LEAP project back in a few years ago. But we also have done some new work for developing the orchestrators that we needed here, especially the batch orchestrator that we need for labeling data at rest. That was a component that was basically written for this particular sandbox. But also the work of maintenance of those open source projects that we brought in, there needs to be work, in updating and maintaining all the dependencies. So those are active components that are going to be residing in the sandbox. And what we have here on the screen also, these are some of the screenshots of the upcoming work that we haven't rolled this out yet, but the work is going to be available soon, that we will have a clean interface. We'll have the data, the sample data, the synthetic data that we have, in accordance with the use cases that were targeted. And then we have these technical components that are going to be actively available for testing and integration. And then we'll have this interface for developers and engineers to be able to actually interact with the system, sign up and actually get access to these components in order to be able to build and show how these things will work. And I think ultimately one of the major goals of the sandbox is to have these components available and also provide the flexibility to show different permutations of these components, because these are the ingredients that we need, and there might be more complex use cases that will require a different flow or different composition of the services. So the goal is to actually have all these services up and running, and for example, the security labeling service can be used, for example, independently to incorporate into a different workflow than the ones that we have shown so far. So that's sort of like the work for the sandbox, and we are hoping that that work will facilitate further integration with new partners and other members as they join Shift, the Shift initiative. So I'm going to pause here. I think that we might have some time for questions at the end. I apologize. I think I was a little bit distracted. There was a bit of an echo that constantly was bothering me. So I think I feel better now, but it's closer to the end.
No problem. We're actually going to pass it off to Tim here just to talk about the Drummond and Shift partnership before we open it up for questions.
Yeah, thanks. You guys can hear me okay, Serena? Yep.
Yeah.
Okay, good, great. Yeah, so I'm gonna just spend a couple of minutes to kind of talk about sort of Drummond's role in this ecosystem of sort of preserving a patient's privacy and their consent. Now, Drummond's sort of role sort of in the ecosystem is to help drive adoption of standards and from a conformance standpoint and from an interoperability standpoint by performing the testing and the certification that's necessary as implementers sort of implement standards and then how they sort of then sort of roll out their different services and their implementations in the broader sort of real world ecosystem of how a patient's data then is sort of shared throughout the ecosystem. How does their privacy and their consent sort of be preserved as their data is exchanged? So Drummond kind of thinks about how how this sort of plays or parlays out into the broader ecosystem of the data sharing. So Drummond has been helping to drive adoption of health IT standards for now over 15 years, and even beyond that, we've been working at how do we drive the interoperability of secure data exchange for now over 25 years in domains, even beyond health data. But in particular, our focus now is how do we help guarantee interoperable data exchange. And personally, I've been, and the reason why Drummond is involved with Shift is how do we make sure that a patient's data is privatized, throughout its sort of life cycle. So to sort of do that, we have built this sort of initiative called FHIRplace, because now the data is being exchanged through lots of times now through these FHIR technology, and so with FHIRplace we envision bringing together the implementers of FHIR technology across the whole board, but obviously we're focused here on tagging the data and the consent management of it, but bringing together a community of FHIR implementers and their end users so that we can sort of test, as sort of Mohammad was kind of going in with a sandbox, how can we test these implementations, and whoever uses it, these implementations, whether that's providers or payers or other members of the ecosystem, how can we test this at scale and in a real world way? And so we don't want to just focus on is someone conformant to a standard, but how does this data flow interoperably, but also how is the patient's privacy sort of maintained as their data kind of flows throughout the ecosystem. Next slide. So the elements of FHIRplace are, yes, various different levels of testing. Yes, conformance to the FHIR standards through testing with tools is important. But what we really want to get to is bringing together the actual implementers and the end users so that they can, once they begin to implement these standards, are they interoperable? So help them test with each other, help facilitate one-on-one testing, and then eventually bringing together many implementations, many provider systems, many payer systems, many different services. Here in the context of what Mohammad was sharing, the tagging services or the consent management services, the redacting services, how they all sort of interact with the broader community in real use cases, and we call those sort of full matrix testing scenarios, where we bring together many services so that they can test with each other, so that we're not only thinking about, is everyone conformant to a standard, but is everyone interoperable with each other as this data is exchanged, and is patient privatized data maintained throughout the sort of life cycle of how a patient's data is shared across the ecosystem. And you can go to the next slide now. I think that's it.
Yeah, thanks, Tim. So now we've come to the slide that you've all been waiting for, as you've been sitting here for the past 45 minutes. How can you get involved? Because I know that all of you have been sitting here saying, this is such amazing, exciting work, such really important work for everything that I think we all do to try to really improve interoperability, improve data standards, and ultimately with patients and families sort of at the center of it, and really for us a shift with trust, improving trust at the center of it. So if you want to get involved, join our next stakeholder meeting. It's next Tuesday, 11 a.m. Eastern. I'm going to put up a slide to show you how to do that. You can tell others about what we're doing at Shift, and help them know that Shift is the place that they can get involved to join this exciting work. We are particularly looking for more patient advocacy organizations. We have a number of patient and caregiver advocates who have joined, but we are looking for national patient advocacy organizations that we would love to connect with and support our funding opportunities. If you know of grant opportunities that you would be able to send our way, or would like to partner with us for grant opportunities, we would love to hear from you as well. And then this next slide, this last slide, is the one to take your screenshot of or your picture of. This is where to find us on all the socials and how to join Shift. That little QR code or the URL is our little form. You can join our distribution list. We don't send out lots and lots and lots of emails, don't worry. And how to join our large group meetings or any of our work streams or advisory groups if you should so choose. So we'll leave that up there while we ask if there were any questions that came in.
Yeah, we have a few questions here. I'm going to take the first one from Edward. I'm going to address this to Hannah first. What is the biggest barrier that you've heard from vendors, implementers, and how are we addressing it?
Yeah, it's a great question. There are two really big barriers that I hear from vendors and implementers. One is a lack of harmonization around state laws and terminology standards to that matter. And so the Shift's terminology group with HL7, this cross-paradigm work group, is working directly to address that, right? If we can get VSAC value sets that the states can look to. So Maryland isn't developing their own value set and California isn't developing their own value set. That is one big barrier that we are trying to help overcome. We're working closely with Sequoia, who is writing out with our assistance some recommendations for the state to use the standards-based approaches that Shift is developing, so that states don't keep reinventing the wheel over and over again. That's a nightmare for vendors to have to build to every jurisdictional law. The other big barrier is a cost barrier, right? And it just takes a lot of time and resourcing to develop. And the Shift Sandbox is one of the areas that we're building toward to help with that type of testing and validation. to help with that cost. We've also advocated with ASTP to say that, you know, it is very hard to require a standard without some type of incentive. We understand how difficult that is for vendors. And so working in this sort of incremental approach, use case by use case approach, to not boil the ocean, but to really prioritize use cases and work directly with our vendor partners to help advise on those implementations. Because trying to do it all, trying to implement granular segmentation of everything would be incredibly resource and cost prohibitive, I think, even for the most, the biggest vendors right now. So, so those are some of the ways that we're trying to help in that regard.
All right. Well, I'm going to pass it over to Timothy to answer Adele's question here. What is the benefit of hosting via Fireplace versus participation in a connect-a-thon?
Yeah, this is a great question. So, and one that's often asked, you know, when we start talking to folks about Fireplace, we love connect-a-thons. We go to connect-a-thons. Connect-a-thons are important for, you know, testing a standard and implementation guide, especially among early adopters. Is this, are we on the right track with developing the standard? Gives us some good early feedback on it. And connect-a-thons have great value, as does pilot testing. All of those sort of do you know, some real world testing with implementations against each other. But the limitation of connect-a-thons are they only happen once or twice, maybe 3 times a year, and they're very short-lived. They're only for a couple of days. And what we're trying to accomplish with Fireplace is, with some of these complex fire use cases, I know here we're talking about you know, privatized data and consent, but Fireplace addresses, you know, other complex fire use cases like prior authorization, or maybe one day patient cost transparency, where we're talking about multiple different actors that's involved in it. And we're going to need another level of testing beyond the connect-a-thon. We need to test robustly and at scale for weeks or months at a time in order to really ensure that these things are not only that they just work at a base level, which is what we do at a connect-a-thon, but are they interoperable, and can they scale to really real world conditions. And so that's what's distinguishing about Fireplace, is that we're kind of taking the connect-a-thon idea and really putting it on steroids, and then ultimately trying to bring together as many pieces that's going to exist in the world at the same time. So you know, is your privatized data going to be preserved when you go and are going to have a prior authorization event happen, or if you're going to have a care coordination event happen, or you know, as your data is sort of being shared for all kinds of decisions, you know, in the real world. That's sort of hopefully that answers your question, how we want to you know, test all the different aspects of real world health data exchange.
Thank you, Timothy. Real quick, I know I answered this in the chat, but Janice asked when we can see the Sandbox. We are going to be kind of unveiling it, officially launching it on our October 7th stakeholder call. So not our next stakeholder call, but the one afterwards. And again, that join link that we had earlier can point you in to how to join that call. And then it looks like we have a final question here for a final couple of minutes here from Gary. How do you measure success in this collaboration, and what outcomes should stakeholders expect by the end of 2025?
I'll take that one.
Great.
It's a great question, Gary. We measure success with a different metrics based on the work stream, right? So, and right now, a lot of these are more process metrics. So for the end of 2025, we will not quite be done with the last Delphi process. We'll be close. The goal will be to be done with the last Delphi process by early 2026, the first month probably of 2026. So, so we do have roadmaps for sort of each work stream. So, and we will be publishing the results of these Delphi processes in peer-reviewed journals. So we will hopefully have submitted some of the other previous Delphi process results. We're currently writing up those manuscripts in peer-reviewed journals. So that's implementation. Terminology, we're still sussing out what is reasonable, what are reasonable timeframes for success in the terminology space. There is a lot dependent on the terminology value sets, and so we're trying to move that work forward quickly, but we're still figuring out what is a reasonable timeline. We're focused right now on the California AB 352 law, the Maryland law. There's a brand new law in Massachusetts. So we're focused really on those 3 jurisdictional laws in terms of the value sets, which are mostly reproductive health, gender affirming care, I think in vitro fertilization, so mostly in the reproductive health space. And so, those value sets, we will determine success by publishing open source VSAC value sets. The timeline on that is still a little up in the air. With the Sandbox, we are going to measure success by having a sandbox that is available to both demonstrate these use cases, all 4 of the use cases. We have actually a couple of extra use cases in the parking lot, but these 4 primary use cases in our UI, right, showing the sort of redacted data with a sort of shift kind of almost summary of care record view, and also allowing other vendors to connect via API to demonstrate it directly in your UI. Now, there are multiple sort of tiers to this and multiple kind of iterations. And so by the end of 2025, our goal was to have this be one of the Sandbox up and running. And that's what we will have as we'll demonstrate on October 7th. In 2026, our goal will be to have a version 2 of the Sandbox where multiple vendors can connect, and will demonstrate additional connectivity, and hopefully to be launching with Drummond the Fireplace. So those that stay tuned, join our large group meetings, hear more about our roadmap and what will be scheduled and available in calendar year 2026. But great questions.
Thanks. And if I may add one more point, as we have 1 minute left, with the software components, we can define milestones, but it's a never-ending process. So it's a continuous refinement, and so the criteria of success would be kind of evolving as we do more work. So every milestone we reach, we'll have the next milestone kind of in sight, and we'll be reevaluating the criteria of success for the next step.
Great point, Mohammad. Thanks.
All right.
Thank you very much, everyone, for your questions.
Yeah, and huge thank you to the Shift team and huge thank you to the Drummond team for taking time today, and for everyone that joined the webinar. The next webinar that is open for registration, you can scan the QR code on the screen here, September 25th, Cybersecurity and Compliance Automation for Health IT Vendors. And if you have more questions about Fireplace, you can scan the other QR code you see to book a consultation with Tim. So thank you, everyone, and we look forward to seeing you at the next webinar.
Thank you.